Welcome to this month's Minute with Victor, where Dr. Cotton answers your questions.
This month's question comes from a physician who writes, "A few months ago, you said we should always manage Coumadin by the book. But this isn't possible with some patients because they're unable to follow instructions and their INRs are all over the place. This is dangerous, but without Coumadin, they're at risk of stroke or PE. What are your thoughts on these situations?" I think you should consider stopping the Coumadin. Now, you're probably thinking, but if the patient has a stroke, I'll be on the hook for malpractice. No. If the patient has a stroke, that would be a mal-occurrence or a mal-result. But malpractice isn't defined by the result. It's defined by the way we practice, which is why it's called malpractice, Latin for bad practice. So rather than worry about the result, which we can't control anyway, we should focus on the way we practice, with the goal of giving the patient the best opportunity for a good result. Now, with that as our guide, if you stop the Coumadin on these patients, their risk of stroke might be 5 or 10% per year. But if you continue it in the face of their poor compliance, their risk of a fatal bleed might be 20 or 30% per year. And if that's indeed the case, then you should stop the Coumadin. Now, when you reach that point, I'd thoroughly discuss the situation with the patient and document my reasoning in the record, and then I'd look for other options. Perhaps the patient can take a different anticoagulant. Perhaps he needs a greenfield filter. Perhaps his best option is simply to live with an increased risk of stroke. And while that's not ideal, if it's your best option, then it's certainly an acceptable way to practice. One might even say that it's good practice. It's certainly not bad practice, and that means that it can't be malpractice. Thanks again for listening.